Bismillahirrahmanirrahim. Today our topic of discussion is going to be acquired heart diseases. We have already covered congenital disorders. Now we are going to move on to this topic. Most of these things are to be covered by physicians because surgery doesn't really have a role to play in most of these disorders, but still we have to cover them, so we'll do them a bit rapidly. We won't go into much unnecessary details. So first things first, what are acquired cardiac diseases? These are diseases affecting the cardiac tissue and function which does not have its inception at birth and usually is secondary to an external agent. These are the things that the patient develops after birth, any time after birth, even in pediatric age group or adults. So anything which the patient is not born with. What are different types of cardiac disorders? There are ischemic disorders, there are hypertensive disorders, there are infectious disorders, inflammatory, metabolic, nutritional, or traumatic disorders. If we quickly consider the ischemic disorders, they are mostly occlusion of the coronary vessels, either due to atherosclerosis or Kawasaki disease or sickle cell anemia, in which the cells change the shape in areas of low oxygen tension and block the vessels. Or they may be due to hypoperfusion. Hypoperfusion means the reduced blood supply. It may be due to surgical ischemic arrest or due to severe hypertension or asphyxia. Asphyxia is basically a respiratory condition, but it has its implication on the heart as well. Hypertensive disorders may be systemic hypertension, in which the blood pressure is high and generally high anyway check in the body, and it may also be simply pulmonary hypertension, as we discussed in the shunts in the previous lecture. Gradually the blood pressure in the pulmonary vasculature rises, and that is called pulmonary hypertension. If we talk about infectious disorders, they are pericarditis, myocarditis, and endocarditis. The word itis means inflammation, so inflammation in any three of the layers of the heart: the pericardium, the outermost layer; myocardium is the muscles of the heart; and endocardium is the innermost layer. If any one of these is inflamed, we call them as such. Continuing with the inflammatory conditions, post-pericardiotomy syndromes, in which if we have performed a surgery, or if the pericardium has been opened for any other condition, or post-operatively inflammation may set in. Rheumatic fever, this we will discuss in detail because it's a very important topic. Collagen vascular disorders also lead to cardiac problems. As far as metabolic disorders are concerned, endocrine adenopathies related to the adrenal gland, to the pituitary gland, to the pancreatic tissue, to the thyroid or the parathyroid, all of these eventually affect the heart in one way or the other. Nutritional deficiency, for example, during periods of starvation, or if a person's diet is low in vitamins or minerals, they may also affect the heart. And even nutritional excess, as in obese individuals, due to excessive fat deposition in the body and in the pericardial in the cardiac vasculature, the problems may arise. And trauma, as always, trauma may be penetrating or blunt. We are not going to discuss all of these in detail. We are just going to discuss briefly the important points, important conditions among these. So the first thing is Kawasaki disorder. This is an inflammatory disorder of unknown etiology. There are certain immunoregulatory anomalies. What this word immunoregulatory anomalies means is this is an inflammatory response in which the body's own immunity starts destroying and affecting the normal tissues as well. There is a generalized microvasculitis. This disease usually affects small vessels and arteries, and it affects the whole body, not just the heart. There is, in addition to the microvasculitis, there is myocardial and pericardial inflammation, and there is coronary vasculitis as well. So how does it present? It presents with the main presenting feature is fever which has been present for 5 days or more, along with various physical findings. For example, there is a rash on the skin, polymorphous rash, polymorphous meaning it may be of different shapes. There is non-purulent conjunctivitis, inflammation of the conjunctiva without pus. There is erythema of the oral membranes, including the tongue. There is indurative edema of the feet and hands, and there is cervical lymphadenopathy. It's not necessary for all of these to be present. If any 2 or 3 of these are present and there is a history of fever for more than 5 days, we can label it Kawasaki disorder. How can we confirm our diagnosis? By doing a few blood tests, where first of all we'll see elevated acute phase proteins. An example of these is the C-reactive protein, CRP. These inflammatory proteins are raised in any kind of inflammation, not specifically in Kawasaki disorder. Patient's ESR may be raised. ESR is another general indicator of chronic diseases. Elevated platelet counts, myocardial dysfunction, which may be exhibited by getting an ECG done or echocardiography done. Pericardial effusion, again it will be visible in the echocardiography. And if you find coronary thickening, which is dilation of aneurysmal dilation of the coronary vessels, this is very much suggestive of Kawasaki disorder. So how do we treat it? We give intravenous gamma globulins, the active proteins which fight against these problems, and acetyl salicylic acid. It's ASA simple and over the counter and available as over the counter analgesic as well. These are a few things that you may see in Kawasaki disorder. In the first picture you see there is a rash, then the condition of the tongue, and again hands and fingers are involved as well. So the next thing, diseases of the pericardium. Pericardium is the layer that surrounds the heart, like pleura in the chest or peritoneum in the abdomen. Pericardium is the layer which is surrounding the heart. Again, it has 2 parts, a visceral pericardium and a parietal pericardium. There's very small amount of fluid in between these two, not more than 5 to 10 ml. So what happens when pericardium becomes inflamed? We call it pericarditis. This is inflammation of the pericardium, and this inflammation may be due to some infection or due to some other etiology. So if you just briefly consider the etiologies, it may be infective, for example by infection by a virus or a bacteria or fungi, or even parasitic. I will not go into details of which bacteria or which viruses. You don't need to memorize those either. Some autoimmune disorders like SLE or drug-induced lupus or rheumatoid arthritis, they may also lead to inflammation of the pericardium. Malignancies, neoplasm, primary mesotheliomas or secondary metastatic tumors may lead to pericarditis. Radiation pericarditis, and patients who have undergoing radiotherapy for some other treatment of some other tumor, they may develop pericarditis as well. Renal failure or uremia, that is an independent cause of pericarditis. Trauma to the pericardium, penetrating trauma most commonly leads to an infecting organism being pushed into the deeper layers and up to the pericardium and getting seated there. And some cases may be idiopathic. Idiopathic means that you cannot find a definitive cause for the disorder. So what actually happens in pericarditis? The first thing, there is inflammation, and due to inflammatory cytokines there is vasodilation. This vasodilation allows transudation of fluid into the pericardial space. Next step is increased vascular permeability, which allows the proteins to leak into the transudative fluid. And thirdly, there is leukocyte exudation, most commonly neutrophils, and all of these, there's fluids and proteins and neutrophils, they accumulate in the pericardial space. What are the different types of pericarditis? This you need to memorize. Depending upon the underlying cause and the severity of inflammation, it may be serous pericarditis, in which there is only serous fluid. Serous fluid is like transparent, colorless fluid which doesn't have any blood or any excessive amount of protein in it. There may be serofibrinous pericarditis, in which there is a small amount of fibrinous cells as well. Then it may be suppurative. Suppurative means pus. The pericarditis, if it's due to secondary to a bacterial infection, the pericardial space may contain pus, or it may be hemorrhagic pericarditis, in which the blood cells become leak into the pericardial space and blood accumulates there. So how will the patient present? The most common, the most important presenting feature will be pleuritic chest pain. The patient will tell you about pain which is localized to the left half of the chest, and it increases and decreases with breathing. Again, there will be inflammation. Whenever there is active inflammation, or infection in the body responds by producing a fever. There may be pericardial friction rub. You can auscultate it, and if you get an ECG done, you can see various findings like ST elevation or PS segment depression. So what test can we do to diagnose it? First and foremost, we get an echocardiogram. An echocardiogram is a simple ultrasound of the heart and its chambers, and it will tell you about presence of fluid in the pericardial space. Next, you may get different blood tests. For example, PPD, this is purified protein derivatives that you can find in the blood, or RF, rheumatoid factor, if you're suspecting rheumatoid fever as the cause, or ANA, anti-nuclear antibodies, which are present in various connective tissue disorders, or you can simply get viral titer. Depending upon the cause, the diagnosis will depend, the investigations that you perform to get to a diagnosis will depend upon the etiology, the suspected etiology. If the suspected etiology is a tumor, then you need to proceed as such. You get a CT scan, or you get a contrast enhanced MRI, which will tell you good, it will give you good information. And if everything else fails, you may perform a therapeutic or diagnostic pericardiocentesis or pericardial tap. You just pass a needle into the pericardial space, you aspirate that fluid, and you get a complete examination done of that fluid. It will usually tell you the cause. So if the patient has developed pericarditis, you diagnose them. Now what do you do with them? The first thing, you give a good analgesic. Most commonly analgesic given are NSAIDs, and analgesics, these NSAIDs also have an anti-inflammatory property. In my own personal practice, I usually give brufen. Ibuprofen has a very good analgesic role as well as a anti-inflammatory role as well. If it's a recurring pericarditis, then you may use steroids. These steroids have dual role. First thing, they will reduce the inflammation, they will reduce the inflammatory response. Secondly, if the inflammatory response is already established, these steroids will at least slow down the procedure, the steps towards fibrosis of the pericardium, because once the pericardium becomes fibrosed, it will cause problems for the heart during its function. If you're suspecting a bacterial pericarditis, you should give antibiotics, or if you're suspecting a fungal or things like that, depending upon the cause, you may give antivirals or antifungals as well. If the cause is renal failure, obviously the patient will need dialysis, and if the cause is a tumor and you think that tumor is inoperable, then you need to proceed to radiotherapy or chemotherapy. So simply all of these things depend upon the cause, and there is no role of there is no active role of a cardiac surgeon anywhere in here. Pericardial effusion. This is a continuous process. First there is inflammation, which we've just read, it's called pericarditis. But after pericarditis, when the inflammation has been present for a while, it leads to accumulation of fluid in the pericardial space, and that is called pericardial effusion. Some of the etiologies are same as we discussed for pericarditis, but there may be a few other things as well. For example, obstruction of the thoracic duct may lead to accumulation of fluid in the pericardial space, and this effusion may be serious, serofibrinous, suppurative, chylous, or hemorrhagic, almost same as that we discussed in pericarditis. What are the clinical features? Small effusions will remain asymptomatic as long as they are not causing problem for the heart to function. They will remain asymptomatic. But if the effusion becomes big, then the patient will start having hemodynamic disturbances. If this large collection of fluid is compressing the surrounding structures, it may give rise to other features. For example, dysphagia, which is due to compression of the esophagus, hoarseness, which is due to compression of the recurrent laryngeal nerve, or hiccups due to irritation of the diaphragm, and dyspnea due to hindrance of the lungs to properly inflate or deflate. As you can see in this diagram, there's a space around the heart, and this bluish color thing, this is the pericardial effusion. Next step, after first step was pericarditis, then pericardial effusion, and the third step in this sequence is cardiac tamponade. Cardiac tamponade has already been discussed in chest trauma, but we'll discuss it briefly here again. This is fluid in the pericardial space under high pressure compressing the cardiac chambers. It elevates the filling pressure, it impedes the ventricular filling, and it decreases the cardiac output. So this is the basic difference between pericardial effusion and cardiac tamponade. Pericardial effusion is simply a presence of fluid in the pericardial space. Usually it's not under too much pressure and it's not causing too much problem with the heart's function. But if the pressure becomes too much, or if it starts messing with the heart, then we call it cardiac tamponade, and this cardiac tamponade is life-threatening. It may lead to cardiogenic shock. So we do not take this lightly, and we have to treat it urgently. Clinical features of cardiac tamponade have already been discussed. They are the clinical features of cardiac tamponade have already been discussed with you guys briefly previously. But the patient usually presents in shock. The patient is confused, he is agitated, the blood pressure is very low, and if you examine the patient, you will find that the heart sounds are muffled and you cannot find the epic speed and things like this. You've already been discussed with you guys previously. One important thing that I think we didn't discuss previously is pulsus paradoxus. What is pulsus paradoxus? It means that the pulse, if you're just examining the radial pulse of the patient, it will alter with inspiration and expiration. As you can see in this diagram, during inspiration the pulse will become weak because the heart is already under pressure because of the cardiac tamponade, and if the lungs also start compressing it from the sides, it cannot properly compress the blood out, and the cardiac output reduces and the pulse becomes weak. But during expiration, when the lungs are relaxing and the heart has a bit more space, the pulses again become appreciable bit more. So this alteration of pulse with breathing is called pulsus paradoxus. How do you diagnose? You get an ECG scan. It will show you a low voltage ECG, sinus tachycardia, and if you get an echo done, the echo is usually diagnostic for these things. It will show you pericardial effusion under high pressure. You can rule out the other anomalies as well. So what do? First thing, we perform a pericardiocentesis. We push a needle into the pericardial space, usually under ultrasound guidance and with cardiac monitoring as well, and we aspirate the fluid. But if it's recurring pericardial effusion or a cardiac tamponade, then you might need to do a pericardial window. You just operate and you make a small window in the pericardium so that the fluid does not accumulate there and it just comes out and gets absorbed in the surrounding structures. Or you can do a balloon pericardiotomy. You just pass a balloon catheter and you open up the pericardium using that. This is a sequence of events. First there is inflammation, first there is pericarditis. This pericarditis leads to pericardial effusion, which is excessive fluid buildup in the pericardial sac, and if the pericardial effusion becomes under pressure, it becomes too big and starts messing with the heart's function, then we call it cardiac tamponade. There's another thing here, Beck's triad. We will discuss that also. That is very important to diagnose a case of cardiac tamponade. Beck's triad is present of three things: hypotension, jugular-venous distension, and muffled heart sounds. We have when we discuss trauma, we discuss two things: tension pneumothorax and cardiac tamponade. These are the most rapidly lethal conditions related to the chest that a patient may present with. So, and the problem is that their presentation is very much similar. The patient presents in shock, and you have to treat them urgently within half an hour, or you will lose the patient. So we need to know very clear-cut signs symptoms for cardiac tamponade and tension pneumothorax. The Beck's triad, hypotension, jugular venous distension, and muffled heart sounds. If these three things are present, you directly think of cardiac tamponade. But in tension pneumothorax, heart sounds are normal, and instead of muffled heart sounds, you will have absent breath sounds. This third thing is difference between cardiac tamponade and tension pneumothorax, and obviously the treatment for the two is very different from each other. So moving on to constrictive pericarditis, if the pericardium became inflamed and if you treated it, sometimes it may become fibrosed, and this creates problem for the heart to function. Constrictive pericarditis is a late complication of pericardial disease in which the pericardium becomes fibrosed like a scar tissue, and the two layers of the pericardium fuse with one another and they form kind of a thick envelope around the heart. How do we diagnose it? If it's calcified, you'll be able to see it very well on chest x-ray. An ECG will not give you any specific information, and the best thing you can do is you can get a CT or an MRI done, which will give you a very good picture of the pericardium, and eventually you will have to excise this fibrosed pericardium. There's no other way to treat it. You have to excise it. Congestive cardiomyopathy or myocarditis, this is infection of the myocardium, of the muscles of the heart. This is a degenerative process that affects the myocytes, the muscle cells, and due to these degenerative processes, there is an impairment of the myocardial function. As you can see in this picture, this usually involves ventricles because ventricles have thicker muscular walls. Clinical manifestations are generalized malaise or viral syndrome. What is this viral syndrome? In almost all viral diseases, there's a kind of a generalized malaise, and you don't feel well. You might have a bit of nausea, you have a headache, there's a specific pattern of fever. All of these things are combined are called viral syndromes. Along with this, the patient may also have chest pains. Patient may have tachyarrhythmias. Tachycardia means increased heart rate. Tachyarrhythmia means the heart rate is increased as well as it's abnormal. The beats are not coming in regular sequences. The patient may even present to you in shock if the cardiac function is impaired too much. Echo will give you good information about the valve motion of the muscular walls, or the valves functioning properly or not. Diagnosis depends on clinical findings. It also depends on finding the causative agent, and echo will give you some information but not too much. If you want a definite diagnosis, then you need to get a biopsy of the myocardium. That is but difficult to do, so we just treat it empirically. How do we treat it? We gave the patient, first of all, we gave symptomatic treatment, inotropic support to the heart so that the heart can keep on beating, diuretics to reduce the preload. The fluid coming into the heart should be reduced so the heart has to function less, and afterload reduction, so the heart can pump enough blood to reach the peripheries as well. Afterload reduction works in a way that we usually give vasodilators, which will lead to peripheral pooling of the heart in the veins, and blood will stay there. It will not return to the central circulation too much, and things like this. You correct the etiology, whatever is the cause, you treat it, and you give immunosuppression, because some of the etiological causes are related to autoimmune disorders. And if the heart is too far gone, then you may even consider the patient for a transplant. Infective endocarditis is a microbial infection of the endocardium, of the innermost layer of the heart. It may be acute, which is due to viruses usually, and it may be subacute, which has a gradual and a longer course. Main etiology in this case is a bacteria, alpha hemolytic streptococcus. It may be due to other bacteria or due to other pathogens as well. Risk factor that to make a person prone to infective endocarditis are prostatic valves. Whenever the patient has been operated and put on a prostatic valve has been put in, he is at risk. Surgical shunts, again post-operatively, indwelling catheters, or a previous episode of bacterial endocarditis. Moderate risk category is present in those patients who have congenital cardiac defects or rheumatic heart disease or mitral regurgitation and mitral valve prosthesis has been placed in. Clinical manifestation, how will it present? It will present with viral syndrome, similarly as we discussed previously, and it may present with fever. New murmur that wasn't present before when the patient became ill. If a cardiologist has seen the patient previously and then he sees him again, he might find a new murmur. The patient may present with symptoms of congestive heart failure. Patient may have petechiae. Petechiae are small bluish spots on the skin in the peripheries. These are microhemorrhages under the skin. The patient may have increased ESR, anemia, or even blood in the urine, hematuria. So this is the finding in the hand, and these are vegetations on the inner surface of the valves. Vegetations, bacterial vegetations. How do you diagnose? You get a blood culture. If there's bacterial colonies in the heart, obviously they'll be pumped out into the blood as well. So if you get a blood culture, it usually gives you a good diagnosis. If the culture comes out negative, then what you need to do is you need to keep the patient away from all sorts of antibiotics for at least 24 hours, preferably 48 to 72 hours, and then you need to repeat the culture again, because if you've given any antibiotics, they may have killed the circulating bacteria and you may get a false negative. If you get an echo done, you might see the vegetations which are present just on the inside of the valves, or even dysfunction of the valves themselves. The treatment will depend on the blood culture. Whatever you get in the culture, you give antibiotics specific to that cultured microorganism. And if the problem is with the valves, then you might consider replacing the valves once the patient has recovered a bit. American Heart Association has also suggested a prophylactic regime in which, in patients who have already had one episode of infective endocarditis and they have conditions which make them prone to having a second episode as well, they are usually put on a regime of antibiotics which they have to keep on taking, and this will include amoxicillin or clindamycin or other penicillins or ampicillin, gentamicin or vancomycin. They may be given in different doses with different intervals. I think the most important topic in today's lecture is this: rheumatic fever. Rheumatic fever is again a medical disorder. Surgeons don't really need to do anything much in it, but I need to discuss it here with you guys. So rheumatic fever is the most common cause of acquired heart diseases in children in pediatric age group. This is due to a post-infection connective tissue response in susceptible host, not in all hosts, but in susceptible host. And these group A beta hemolytic streptococci are responsible for this problem. What actually happens is, when you have a sore throat in which you have this infestation with the group A beta hemolytic streptococci, your body starts producing an immune response against this bacteria. But that immune response sometimes gets out of hand, and that immune response actually starts damaging various organs of your own body which have similar antigenic properties to the invading microorganism. So different systems may be involved. Bones, joints may be involved. The patient usually has arthritis. Heart may be involved, leading to myocardial issues. The brain may be involved. The skin may be involved. We'll discuss them further. This Jones criteria is a diagnostic criteria for rheumatic fever. If at least two of the major criteria or one major and two minor criteria are present, then we can label the patient as having rheumatic fever. What are the major criteria? This depends upon areas of the body involved. Joints, if the patient has polyarthritis, involvement of multiple joints. if the patient has myocarditis, valve damage, if the patient has subcutaneous nodules present usually on the external surfaces, if the patient has skin rash, erythema marginatum, or if the brain is affected, the patient will have sydenham chorea. All of these are major criteria. So if any two of these are present, you will label the patient as having rheumatic fever. If we consider the minor criteria, this is a mnemonic to memorize these. Jones piece. P stands for previous episode of rheumatic fever. E stands for ECG abnormalities. A stands for arthralgias. These are pain in the joints, not inflammation. C stands for elevated C-reactive protein or ESR, and E stands for elevated temperature or simple fever. So two major criteria or one major with two minor criteria. If they are present, then you will label the patient as having rheumatic fever. So these are some of the findings you'll see. Most of these are skin rashes, or these are nodules on the external surfaces, and this is where it all starts. Group A beta hemolytic microorganism infecting your throat. Arthritis is the most common manifestation present in about 60% cases of rheumatic fever. This is monoarticular, usually involving larger joints, or it may be migratory kind of arthritis, so it's involving one joint today, and after a few days it may be involving some other joints as well. And as I said, this is monoarticular in most cases, not in all. It may be polyarticular as well. It gives a good response to ASA, acetyl-aminosalicylic acid, and there is usually no residual effect. Once the patient starts to resolve and the patient starts to recover, the joints become fine, and there is no residual problem with the movement of the joints as well. The second most common presenting feature in rheumatic fever is the carditis. This usually comes 1 to 2 weeks after the infection, and the infection may involve endocardium, the valves, the myocardium, or the pericardium, any part of the heart. If a prior attack of rheumatic fever is present, the patient will have more chance of developing these inflammatory problems in the heart. But this is among all the other criteria. The carditis is the only criteria which will have, if it's there, it will remain. Even if you treat the rheumatic fever, the cardiac problem will remain. It will become permanent. That is why this is more significant than the rest. What investigations can you do? You can get a throat culture. You want to culture the causative bacteria. You can get a complete blood count, which will show you elevated ESR, elevated white cell count, or hypochromic microcytic anemic picture. In ECG, you might find some abnormalities if the heart is involved. X-ray will show cardiac enlargement, and obviously an echo can help you out a lot. What's the treatment? First of all, you do the general measures. You advise the patient take proper bed rest, to take proper diet, to take adequate amount of fluids. The joints which are involved are usually immobilized temporarily, not permanently, and you just start mobilizing the patient as soon as possible. You give ASA, which is good analgesic in these cases. You give benzyl penicillin. These microbes usually respond really well to penicillin. You may give steroids in advanced cases, again with the same rationale that you want to reduce the inflammation, you want to reduce the chances of fibrosis. And if the heart is too far gone, the patient has developed congestive heart failure, then you need to give cardiac support in the form of digoxin. Prevention is usually recommended for any patient with documented history of rheumatic fever. You have to give these antibiotics almost every day till the patient reaches an age of 21 to 25 years. So the patient might have to be taking one pill every day for 10 to 15 years. Which medicine you'll give? You can give benzathine penicillins, or you can simply give erythromycin. So this is the last topic for today, heart transplant. I'm going to discuss it very briefly. What is a heart transplant? When a patient's heart is diseased so much that it cannot perform its function properly, and the patient is at a continuous risk of sudden cardiac arrest, you consider him for transplant. Transplant might not seem very common in our setup, but there are almost 3,500 cardiac transplants done worldwide, and more than half of these are done just in the USA. and the average post-op survival after a good transplant is almost 15 years. This is an average. Some may live more than this, some may live less. So, what are the indications for a cardiac transplant? First indication is dilated cardiomyopathy. Secondly, ischemic cardiomyopathy. All of these will eventually lead to congestive heart failure. If the ejection fraction, if you perform an echocardiography and you see the ejection fraction is less than 20%, that means the patient will develop cardiac arrest anytime. Congenital cardiac disorders which are not responding to conventional treatment modalities may be considered for a cardiac transplant. Refractory cardiogenic shock. This is actually an emergency case, cardiogenic shock, which is not responding to your treatments. If all your cardiac stabilizing drugs, dopamine, dobutamine, and digoxin, all of those have failed, then you may consider patient for cardiac transplant in emergency settings as well. Or if the patient has recurrent life-threatening left ventricular arrhythmia, obviously then there's no other way out. You have to think of a cardiac transplant. These arrhythmias are usually treated with pacemakers, implanted pacemakers, which are placed near the heart, which try to control the heart conduction. But if that fails, then you might consider the patient for a transplant. As for any procedure, there are some contraindications as well. You will consider a patient for heart transplant only if he has no other chronic illness. For example, if the person has a cirrhotic liver with a cardiac problem, then there's no fun giving him a transplanted heart. Because as you can imagine, a heart transplant, it's not like you can just take the heart out of one person and you can put it in another. These are taken out of deceased donors who have before their death they have given consent that their heart may be harvested and may be implanted into an individual, and that too has to be done within 4 to 6 hours after the donor's death. If you cannot harvest the heart within 4 hours after death, it becomes useless. So you need proper setup, you need proper screening, you need, as in USA, I said there are almost 2,000 transplants done every year. They have proper lists of recipients, candidates who in case a heart becomes available, they just look into that list and they call the person to come into the hospital urgently, and they plan for surgery on the same day. So the next contraindication is a malignancy. If a person has a tumor which was involved in the heart or the surrounding structure, then you usually don't consider him for a transplant because that tumor may grow back into the cardiac tissue. If the person has vascular disease in the cervical or the lower limb vessels, then he's usually not a very good candidate for cardiac transplant. If the person has uncontrolled diabetes, or if there's a history of recent stroke, if there's morbid obesity, or if the person is simply above 65 years of age, in most of our cases the average life expectancy is 63 to 64 years. So if the person has more than 65 years, then it's usually not suitable to give him that heart. Or if the person has history of substance abuse, he has history of using cocaine or drugs or some other type. If let's say you performed transplant, then you need to also consider the post-op complications as well. Some of the most common complications common to all procedures are infections. These infections may lead to sepsis as well, septic shock. With any transplant, the most dreadful complication is a graft rejection. This rejection may be acute or hyperacute or chronic, but in any way, grafts may be rejected. In cardiac transplants, the chances of acute or hyperacute graft rejection is usually less. It's more commonly chronic graft rejection, in which there's gradual deposition of plaques in the coronary vessels, and which leads to failure of that heart as well. Some patients may develop renal failure after a cardiac transplant as well, and this renal failure is usually due to this lifelong immunosuppression using steroids, that has to be done in these patients as long as they are alive. To avoid these complications, you should have adequate control of diabetes and any other medical ailment that the person has. You have to take care of his electrolytes very carefully. You have to make sure that he is taking at least 2 to 4 grams of 2 to 4 grams of sodium per day, and you have to make sure he is taking adequate calcium and vitamin D as well. And considering his nutrition, you make sure his energy requirements are being fulfilled, because after cardiac transplant the patient's basal energy expenditure is almost 1.5 times those of his baseline. So if a person normally needed 2000 calories, after cardiac transplant he is going to need almost 300 kilocalories per day. So you need to take care of his nutritional requirements as well. So this was all about today's lecture. Inshallah, I'll talk to you next time.